Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS learning that you can fit into your busy life. My name is Dawn Liz Powell and I am Medical Editor at MIMS Learning. Today I will be speaking to Dr. Sundhya Raman about lifestyle medicine with a specific focus on people who are South Asian. Dr. Raman is a co-founder and director at My Wellness Doctor. She is both a medical doctor and a qualified lifestyle physician. She believes it is more powerful to truly treat through lifestyle modification than to simply obscure the effects of illness. So Sundhya, welcome to the podcast.
Hi Dawn, thanks for having me.
So your interest in lifestyle medicine, that's actually quite personal for you, isn't it? Because I think your father had quite severe complications of type 2 diabetes, and this sort of made you realise that prevention was actually better than cure?
Absolutely. So my dad, like a lot of South Asians, he was diabetic from when he was in his 40s. And then by the time he was in his 50s, we realised he'd had lots of silent heart attacks. And he ended up needing quadruple bypass surgery at Harefield Hospital, and he had wonderful care there. But then we weren't really tackling the underlying drivers. So despite having optimum medical management of his diabetes and cardiovascular risk, he went on to have more stents into his grafted bypass vessels, and he started to lose his vision. And by the time he was in his 70s, he was completely blind from diabetes, which is a really common complication of diabetes, unfortunately. And so this, of course, had an enormous impact on his quality of life. He lost his independence completely. And of course, my mum did, because she became his carer. So it had a huge impact on the quality of life of my parents. So at a time in their lives when they should be financially independent, enjoying their grandchildren, enjoying a certain amount of quality of life and time, they were in and out of hospitals, they were in and out of outpatient appointments. So it really did impact. And then he sadly passed away a couple of years ago from heart failure. And I think this is quite a common story for a lot of South Asians and a lot of people with diabetes. But then at the same time, my uncle, who was only in his early 50s, he came to me and he had worsening kidney function from his diabetes, and he also was showing signs of progression of diabetic eye disease. So he'd gone from diabetic retinopathy to maculopathy, and having seen what's happened to my father, he really didn't want to, understandably, end up like him. So my journey really began with him saying to me, well, what more can I do? And so after, about a year or so of just saying, well, this is the optimum medical management for you and so on, and really not impacting, just his diabetes worsening, I went back to the studies and I started to research what more we could do. And I didn't know it was called lifestyle medicine at the time, but I started to sort of make changes and suggestions to the way he ate and managed his sleep and exercise and stress. But it was predominantly his diet, his dietary changes. And within a year, we saw that his HbA1c was plummeting and he could come off a lot of his diabetes medication. His kidney function normalized for the first time in 4 years, and it remained normalized. This is about 4 or 5 years on now. And best of all, his diabetic eye damage reversed and has remained normalized now for the past 4 or 5 years, which is incredible. So this was a real lesson to me that, when you start to really address the underlying triggers of this metabolic dysfunction, you can be enormously impactful in outcomes. And that's ultimately what really matters to patients. We can treat their numbers or we can treat their outcomes. And I think when you act at the highest point upstream, then you can really, really make a big, big difference to their lives.
I think that's a really powerful example of how lifestyle medicine can really make a difference. We'll talk about exactly what lifestyle medicine is in a second, but I just want to go back on something, because both your father and your uncle developed type 2 diabetes at a relatively younger age, and in a module for MIMS learning about type 2 diabetes in people who are South Asian, you note that South Asian people tend to develop type 2 diabetes at a younger age than white people. Are you able to explain some of the reasons for this? Because I think it might be a genetic thing. And you've actually got a PhD in genetics and epigenetics.
That's right. Yes. So absolutely. So if we look at what percentage of the population in the UK are from an ethnic minority background, so for example, South Asians are about maybe 8.5% of the UK population, and yet they represent about 30% of the diabetic population. And also when you look at young onset, so under the age of 40, you find again South Asians are overrepresented in this population. And we actually think that it's quite multifactorial, the reasons why South Asians develop diabetes at a younger age, that they're at higher risk at any BMI or weight circumference, and that once they develop diabetes, their precipitation downwards into organ failure and organ damage is much, much more rapid. And so they develop more complications and they develop them earlier, and they suffer worse outcomes when they become pre-diabetic or diabetic. And we think that this is multifactorial in the sense that there's a genetic element, there's an epigenetic element, there is a body composition element, there's factors to do with their socioeconomic backgrounds, and there is also an element to do with how much diabetes medication is escalated in this population. And finally, when we look at lifestyle management, that some of these groups are quite hard to reach in terms of education. And even when you reach them in terms of education, their interventions in terms of lifestyle education aren't really necessarily culturally appropriate. So it becomes very difficult to enable these populations to make lifestyle changes.
Okay, so I think there's two questions there. First of all, and I'm sure our listeners will know this, but what are the basics of lifestyle intervention?
So there are 6 pillars of lifestyle medicine, and what we understand is these are 6 areas in our lifestyle that not just increase our risk of developing all chronic diseases, things like diabetes, type 2 diabetes, dementia, cardiovascular disease, and many cancers, but they also affect the rate at which we progress in these diseases. So it's actually never too late to begin lifestyle intervention to either prevent disease or reverse disease or slow progression of disease. So in terms of these 6 pillars of lifestyle medicine, one is toxic substances such as smoking, illicit drugs, and excess alcohol. The other is social interaction and social connectedness. Nutrition is a major pillar. Physical activity, sleep, and stress management. And not only do they each independently affect your risk, but they each impact on each other as well. So cumulatively, they have an impact. So one, for example, if you're not getting enough sleep, it will also impact on your motivation, your mental resilience, your mental health. But it, as and of itself, will physiologically impact on your risk of developing chronic diseases.
Okay, I think because you were saying that sometimes attempts to engage South Asian people with lifestyle modification aids are not culturally appropriate. Can you expand on that? How could they be made culturally appropriate?
When we look at South Asians, you will often find, for example, that they eat a lot of fruit and vegetables. They often cook from scratch. This is, very culturally normal. So if you look at a lot of populations in the West that have a higher risk of type 2 diabetes, they may have high intakes of processed and ultra processed foods. And so when you're educating these groups, often what you need to do is look at what is specific to their diet that increases their risk. And when you look at South Asian populations, it's often things like refined grains, having a lot of maybe deep fried foods, reheating those oils, which increases the trans fats in those oils, using the wrong types of oils, frying a lot of their breads, for example, having white rice. So these are more the kinds of risks that you'll find in South Asian groups, as well as adding a lot of ghee to their foods. And in many ways, there is a perception that these are healthy foods because historically, if you look at a population with, in India that has a large rural population, the risks are malnutrition and not having enough calories. So having higher caloric intake would probably be considered a healthy option within this cultural setting. So it's really about finding the specific risks to this group and understanding how you can change those. So I, for example, will often say, well, why don't you switch from white rice to brown rice? And pretty much every South Asian will turn their nose up at this. It is not happening. So you have to find alternatives that are more palatable. Whereas when I find with my Western groups, they are perfectly happy to switch to brown rice. And that's because it isn't that culturally normal to just have white rice with every meal. It wouldn't be a big shift in the way that they live. So the alternative I find is asking them to say have cracked wheat or add quinoa or small grains that are high in fiber to that white rice and slowly start to shift the way that they eat. But the things that they do differently and put them at higher risk of diabetes are often different to the risks that I find in white Caucasians.
I think it's interesting what you're saying there about making sure lifestyle modification advice is culturally appropriate, because I think sometimes advice needs to be community appropriate as well. I mean, sometimes somebody's going to be living in an area where that's quite socially deprived, and that's going to affect how they're able to engage with lifestyle modification. For example, the only shops they have access to might not sell brown rice or have a wide variety of fresh fruits and vegetables.
Absolutely. It does also need to be community tailored as well. But I think one misunderstanding is that it is expensive to eat well. And when I did a pilot program using lifestyle to lower cholesterol with a GP practice, we had about a quarter of the participants were from a lower socioeconomic area. And so this question around eating better became quite important. How do you eat better? And what we found was it really did come down to planning. It's really around not just educating people on how to read food labels, understanding what is a better food swap for them that fits in with the kind of way they already eat, but improving upon it. But I think the biggest barrier is for making healthier food choices is not your income, it's not your level of education, because both of these should be addressing at every level, whether that's in schools, whether that's in the healthcare service, and at every opportunity. But it is really, I found, having the right time, the sufficient time to make those changes. And I think that's true no matter what socioeconomic group you're in. I think that you find a lot of people from lower socioeconomic groups and middle class groups, all of us really are not finding the time to cook from scratch and eat healthy foods. And so I think this is consistent. And I think this is the real issue that we're dealing with.
Yeah, I think not only will lack of time and energy affects patients' ability to engage with lifestyle modification, but also GPs themselves can be stretched and they might not have the time to discuss with patients how to make lifestyle changes. How can GPs address this issue?
I do think that we know that GPs, for something like 7.4% of the NHS budget, have 90% of patient contacts. They're already doing an enormous amount, way above what they should be doing for very few resources. I think that this is a really difficult ask. I think that one missed opportunity is the NHS health check. So I think what would be, and there have been modelling studies from a group in Liverpool looking at the NHS health check and how you could make it more cost effective. And they looked at a 23-year window horizon. And they said, well, if we leave the health check as it is, it doesn't really even become close to cost effective. within that 23-year window horizon. If we had 100% uptake and prescription rate, it would only just approach becoming cost effective within that 23-year window. But if you added in a lifestyle intervention, it becomes cost neutral within 5 to 6 years. And beyond that, it's cost saving. Because we know about, according to the World Health Organization, about 80% of all chronic disease is down to modifiable risk factors, largely the way that we live, largely our lifestyles. And all healthcare systems are reactive. Somebody gets sick, they come in, and then we deal with the issue that they have currently. But we know that nearly all chronic disease is down to our lifestyle. So we're not really set up to be proactive, to identify risk and then manage that risk. We do try to do that with the NHS health check, and that's why it's been set up. But what is in place afterwards is inconsistent. So we identify risk for diabetes, and we do have a diabetes prevention program. Unfortunately, there is quite a big fall off from that. But in truth, the majority of people who attend the NHS health check are at risk of developing diabetes, cardiovascular disease, dementia, cancer. We know that the vast majority of us end up with at least one chronic disease. So if we had a very sort of consistent piece of advice for people, this is how you maintain your health, this is how you reduce your risk. We know that most people go on to develop chronic diseases. So if we know that most people are going to end up developing a chronic disease, if we were very, very consistent about the advice that we give, and we already know that our poor diets is the number one driver of chronic disease, according to the Global Burden of Diseases study, then we can start to help people get this reliable information, not from social media, not from the internet, but from healthcare professionals in order to preserve their health. So there are probably a handful of things that reduce your risk pretty much of all chronic diseases. And what we did was, every time we had a patient interaction, we just gave them 2 minutes of advice. And we do know that even 2 minutes of advice can result in behavior change. But I think the fact is that most patients will have multiple interactions with different healthcare professionals, whether that's in the outpatient clinic, whether that's with a practice nurse, whether that's with a GP. And no matter what their risk is, the lifestyle changes are pretty consistent. We know that for tobacco, but we also know that for nutrition. We know that the same is physical activity. And I think there are other things that are more complex, like mental health and social integration and social connectedness. But nonetheless, there are things that, you can start to, through social prescription, for example, start to help people to connect to in order to improve their lifestyles.
Okay, I can't speak for anyone else, but I'm not the best at taking advice, even if it is good advice. How do you deal with a patient who is, shall we say, a little bit resistant to receiving lifestyle advice?
I think one of the most impactful things I found was working with groups of people. And the reason for that is, and this is something I think a lot of people are trying to encourage within the NHS, it's cost saving, because you can see multiple patients at one time with one healthcare professional. The other thing is that patients themselves feel that rather than having a quick 10-minute slot with their healthcare professional, they get to spend an hour there. And they feel like they gained more from that experience. They had more time there. And the other thing is that often when you've only got 10 minutes with a patient, 10 minutes gives that same advice that you may be giving to multiple patients. You can spend that time giving that same advice to a group of patients at the same time. I also found that when you work with groups, they feed off each other. They feel a sense of camaraderie. They can share ideas, they share problems, they share solutions, they share their experience. And I think group consultations is a really impactful way to motivate people, because some people, for example, will think, this isn't that big a problem, I don't feel at risk. And another person's experience, and the fact is that this is their lived experience, may be that, you know what, my dad had this happen and my uncle had this happen, and so on and so forth. And they are much more aware of their personal risk. And this can really transmit in a group environment really, really well.
Okay, so group sessions are a good way to engage people into making changes. What other things should be considered?
I think the other way to motivate people is to, and I think this is a hard ask again, is to see what is really troubling them. I think GPs do this incredibly well, and it's part of their training, which is to see what the hidden agenda is. And we all end up, once you've gained that trust and you find out, well, this is what I'm really worried about, I'm worried about this risk in my family, or I'm struggling with this, then that helps to improve that trust level. And so you're much more likely, once you've built that trust, to have the kind of conversation that is more likely to engender behavior change. It is very, very difficult with what's going on in the NHS to keep seeing the same patients, to see them for follow-up. So I think that ultimately it does need to be a much bigger area of investment in order to support people with behaviour change. And I think that the NHS will struggle if we are constantly trying to act at the later stages of chronic disease and multimorbidity when we know so much of it is preventable. So I think that it is a difficult ask for primary care healthcare professionals to do this, given how much pressure they're under and how few resources they have. But every interaction can count.
I think it's interesting what you're saying there about how every interaction can count. However, does there come a point where you have discussed lifestyle changes with a patient and they seem receptive to it, but you're concerned that you're going to sound like you're lecturing them if you keep talking about it, or that they might become disengaged if they keep hearing the same information?
I think there's always a risk that you end up feeling too paternalistic or maternalistic, and that what you're really saying to them is, you know what, you really should be doing this, you really should be doing that. I think, unfortunately, because of targets and so on, having that longitudinal relationship with your patient has been somewhat lost. And that is more of a systemic problem with the NHS. And I think a lot of people in primary care miss that longitudinal relationship with their patients. So I recognize absolutely this is an enormous challenge. And I don't think that this is for lack of desire by people in primary care to help patients change their lifestyle. I certainly know that when I was doing the lifestyle medicine diploma, the majority of people doing it were general practitioners. They also want to see people reverse disease. They want to see them have better outcomes. They would love to be able to give this advice. And it's a really, really difficult thing to do within 10 minutes. And then also not to be able to just have follow-up appointments and book those in, because there is difficulty for people getting appointments. In terms of the feeling like you're lecturing and that you are starting to annoy, I think it's less to do with routinely saying this and more to do with asking, well, how are you getting on with that? Is there something I can do to help? And that is often what's really being asked there is, can you help me problem solve with the obstacles that I've come across? There are often patterns in why people find behavior change difficult. They may, for example, find they don't have time to exercise. And one small little thing that you can say is that when we look at the graph between health improvements and level of exercise, the instant you begin to increase your physical activity levels, you are seeing a reduction in your chronic disease health risk. So it doesn't matter how much you improve your level of exercise, you will immediately begin to gain the benefits of that. And so there are very small things that you can say that make people feel like, actually, this isn't a huge hurdle to overcome. I can do this little bit and I will start to see the benefits. And that's, I think, one of the key things. It's true pretty much for every aspect of lifestyle change. Even if you don't have to be perfect, you simply have to be on that path in order to gain the benefits. And the biggest benefit goes from doing nothing, like if you do no physical activity and you start to take a 5-minute walk a day, you immediately gain the benefit. And if you have no fruit and vegetables and you have one piece, you immediately start to gain the benefit. So it doesn't matter where you're starting from. As long as you start to see the benefit. And we know that you're already reducing your risk of developing diabetes, cardiovascular disease, dementia, and so on. And so once you start small and you're consistent, that's the main thing. So if people are having problems with finding time or resources or whatever, that is usually it's less about motivating them. It's finding the problem that they are having and helping them problem solve, and sort of then saying, well, what would you like to get to? What time frame would you like to get to that? And sort of just inquiring regularly so it remains at the forefront of their mind. And that's really all you need to do in that setting. You could do more, definitely, and the more you do, the more benefit you get. But if you are time pressured, that would be the number one focus that I would make.
And finally, do you think doctors need to be mindful of the saying, do as I say, not as I do? As in, they've got to be setting a good example? Is it difficult for them to give lifestyle advice if they're not following it themselves?
I think there was a study on this and looking at healthcare professionals and whether they're more likely to give advice on exercise or nutrition or smoking or weight loss and all of these things according to how compliant they are with these various lifestyle choices or lifestyle factors. And there was a strong correlation. And I feel like that shouldn't necessarily be the case. It's possibly a reminder to the healthcare professional that, every time they say this is something they can reflect on as well. We need to have self-care as well, especially given how pressured we are. You don't want to retire and end up with a chronic disease because you didn't end up caring for yourself as well during all of this time. You put all your energy and efforts into caring for other people, but you didn't reflect and do this yourself. So maybe even if we're giving this advice to other people, it is a constant reminder to start bringing it into the forefront of our minds as well. So I don't think it should be that only if you feel you are doing it, you should say it to other people. It may well be that as you say it to other people, you're reminding yourself that you need to implement this into your life as well.
Thank you so much for speaking to me, Sundhya.
Thank you so much, Dawn. I've had a lovely time.
Do check out Dr. Raman's module on type 2 diabetes in people who are South Asian. She has also written a module on young onset type 2 diabetes, which is well worth checking out. Do join us next time when we'll be having a studio discussion about thyroid disease.